There has to be a way for our body to regulate and get back to balance and adjust to what we've done. So 1 liter of fluid that we remove is equal to 1 kilogram, 1 to 1. So 1 kilogram is 2.2 pounds. If you're looking at information about dialysis, it's right here in chapter 50. It talks about hemodialysis and peritoneal dialysis and some of the complications and why one is better over the other. And that's basically what this entire PowerPoint is about. It's more or less chapter 50 in the book. So if I was you guys, I would guess if we're going to get through this PowerPoint, I would go back through and read through 50, make yourself some note cards or some notes about dialysis, answer the questions in the back of chapter 50, and see what you know about these 2 different types, what dialysis does for us, and then what are some of the complications of dialysis. And it does go into infection, clotting off. It talks about disequilibrium syndrome right at the bottom of the page here. Just a little blurb about it. The patient becoming hypotensive, and then it talks about peritoneal dialysis, and that's what we're talking about here. So again, what are some key points about it? Peritoneal dialysis involves instilling fluid, again, into the peritoneal space of the patient, peritoneal cavity. This fluid is hypertonic, meaning that it removes fluid. It kind of like it has a higher gradient, higher concentration of sodium. So water is going to rush toward that dialysis solution. And basically this picture is showing you the peritoneal cavity gets filled with this solution. It dwells for a certain period of time. And the orders will say how many exchange bags to use, how long to let it dwell, and then when to remove it. And basically, this solution, because it's more concentrated in the peritoneal cavity, everything that the kidneys can't do, it removes it with that waste product. And I'll show you a picture of the bag. So how can this be done? Why is this best for the patient? If the patient wants to do dialysis at home, they want to continue to work, they can do what's called continuous ambulatory peritoneal dialysis. Maybe they're only hooked up at nighttime from 8 p.m. to 8 a.m. and then they can go work during the day. So there's good things and bad things about this type of dialysis. Again, what do you have to worry about? What do you think one of the biggest complications would be? Peritonitis. It's infection. Think about what has to happen. This patient every single day has to be able to clean this site off where their access area is, make sure it's really cleaned well, hook up this tubing. What if the tubing isn't clean? What if the tubing was hanging in air too long? What if the patient didn't process it and allowed it to instill too long and it sat in their stomach too long and it became infected? So one of the biggest complications of peritoneal dialysis is peritonitis. What that means is inflammation or infection around the peritoneal cavity. So this has to be somebody that either has a caregiver that can do this the right way. Maybe they have a family member that can hook it up for them. Or maybe the patient themselves is able to follow the commands or the instructions or the education and able to do this in the right way and not get infected. So always think about peritoneal dialysis. One of the biggest risk factors, peritonitis. The best benefits, the patient can stay home. They don't have to go to a hemodialysis unit 3 times a week and get dialysis. So it's a different way of doing it. It's a treatment of choice for older adults. Why do you think this would be best for older adults? Here's the reason. Hemodialysis pulls fluid and electrolytes and does all the waste stuff for this patient in a matter of 2 or 3, maybe 4 hours. So older adults don't really tolerate that fluid change as quick as it has to happen with hemodialysis. Peritoneal is more of a gradual removal of fluid, so older adults tend to tolerate it a little bit better. But remember, older adults have to understand what's happening in order to be able to do it, or they have to have a caregiver, family member, daughter, son, whoever it is that's with them, that's able to hook them up at nighttime. So there's good and bad. You have to think about the patient's cognitive status, Do they have somebody that's qualified and can help take care of them? But when we do have that available, older adults tolerate this better because it's more of a gradual decrease in that fluid in the patient's body. So peritoneal is usually done 8, 10, or 12 hours. There's a specific amount of time that the doctor will order, a certain number of bags that they will order. There's newer machines that actually called continuous peritoneal dialysis machines, and I think I have a picture of one of them in here. That the bags are put in this machine, and the patient can actually, and this just came out in maybe the last 5 or 6 years. We haven't always had these, where the patient can hook to the machine and do peritoneal dialysis overnight while they're sleeping. So again, it's insurance driven. Is your insurance going to cover this? It's expensive. Is the patient able to really put the bags in the machine and hook it up the right way? I mean, there's certain things that you have to think about. So basically, it's a treatment choice for older adult patients, patients who are unable to tolerate anticoagulation, have difficulty with vascular access, have a chronic infection or unstable, have a chronic disease. So look in your book. It says it right here. Who is this recommended for? Why is this better for those patients? Why would we pick peritoneal versus hemodialysis? Remember what I said about hemodialysis. When the patient gets put on hemodialysis, many times, or almost every time, when we're going to access that graft, they get a little bit of heparin, and it's not a large amount, but it is a little bit of heparin that kind of allows the dialysis nurse to access the graft, make sure there's no clots there. When they get done dialysis, the dialysis nurse injects some more heparin to keep that graft from clotting off. So what we're worried about all the time with the graft is clots running in the graft. So you have to recognize that hemodialysis patients get heparin every time they get dialysis. So if your patient has a low platelet count and there's a bleeding risk, wouldn't you think that 3 or 4 times a week of dialysis heparin could affect that? Yes, it could. So that's why we use peritoneal if the patient isn't going to tolerate heparin. Even though it's not IV heparin running through there all the time, it is heparin that we have to give them. Think about this, 3 times a week, every single week of their life. So that's the patient that's better off with peritoneal dialysis. The patient that's high risk of infection from the graft or from the central line catheter, like a diabetic patient, might do better with peritoneal if they can do it the right way. So you just have to, again, it's patient by patient basis, nephrology, patient-based decision. Everybody decides what's best for this patient, what's the best course of dialysis and best recommendation. And there's no one specific, this person gets hemo, this person gets peritoneal. We have to look at the picture of the patient and figure out what's going to be best for them. One thing, if they can't tolerate heparin 3 times a week, they would get this kind of dialysis. If they want to work, if they can't make it to the hemo place 3 times a week, this would be a better option for them. If they're an older adult and they're not going to tolerate that hemodialysis for 3 hours because the fluid's going to shift quickly, maybe this is a better option for them. Again, you just have to think about the patient. If the patient recently had stomach surgery, this wouldn't be a good option for them because their risk for infection will be higher because we're talking about the peritoneal cavity. So you just have to think about what are the best options for this patient based off of the status of that patient. So this is how it works. The dialysis fluid is in this bag or in these exchange bags, and it's basically infused. You have an access port right in their stomach. You're not going to feed them through that. It's a dialysis port. And the dialysis solution is instilled into this peritoneal cavity. This is the cavity that kind of just surrounds our intestine. It's not put into the intestine. It's in the cavity surrounding the intestine. And our blood circulates through there, through the peritoneal cavity, and by the process of osmosis and diffusion, we remove excess fluid from the patient. That's what happens. So this is just a picture of the dialysate solution. The catheter is here. Here's the peritoneum. And basically this catheter is in there. The patient cleans this outside port off surgically, asepsis, making sure it's as sterile as we can get it, hooks the tubing to it, and then allows the dialysate to infuse. And this is just showing you a different picture of that. The peritoneal space around your organs in your stomach is where the fluid is instilled, not in your liver, not inside your intestine. It's in that peritoneal cavity. And then blood passes by, and the waste products that are in your blood are then carried out and gotten rid of when the solution is drained. So this, let me show you a picture. Let's see if I can find a picture. Okay, so here's a machine that a patient might have at their bedside. And look at all the different bags that are here. There's probably about 8 exchange bags there, and the doctor would order peritoneal dialysis, 8 exchanges, infuse for 1 hour, dwell for 20 minutes, drain for 10 minutes. That's kind of how the order would go. What the heck does that even mean? What that means is you open bag number 1, it has a clamp. They're labeled 1, 2, 3, 4, 5, 6, 7, 8. There's tubing here on the end. The patient would be in bed or could walk around with it with some different types of devices. They surgically clean it off, they hook up to this tubing, and you allow bag number 1 to infuse into the patient's cavity. Again, this is all sterile solution. It's not tap water, because you certainly aren't going to put that right into your stomach. So it's all sterile solutions. The tubing is all changed every day. We don't use tubing from last night. It's all brand new tubing. They unhook, unclamp the first bag. It dwells in the patient's peritoneal cavity, and it'll tell you how long it should dwell for. It might say dwelling time 45 minutes. So now it dwells in the cavity, and then after 45 minutes, the patient, there's a clamp right next to where the patient, connects. You'll unclamp that and put the bag below the level of the patient. And then what happens? What do you think happens? The fluid that's in their peritoneal cavity drains back into that bag. That will be bag number 1. Now you unclamp bag number 2. Now that one instills, same process. It creates osmosis and diffusion. All the electrolytes are removed, all the excess volumes removed. It dwells in the patient's stomach for about an hour, whatever the order is. And then we put the bag below the level of the patient, and we allow that to drain out. So one by one, this happens overnight for over 12 hours. Again, companies got better at making machines that automatically do this for you. So when I was a nurse at Peritoneal, we had to do peritoneal dialysis. This was a busy, complicated patient, and not so complicated, but required us to go in and out of the room a lot, right? Bag number 1 had to infuse for an hour. I had to remember to go back in an hour, let bag number 1 drain for 20 minutes, and now 20 minutes later, go back in and infuse bag number 2. That dwells for an hour. I got to remember to come back, so you can see how complicated this patient can be. And you might be doing this in long-term care. There also are machines that we can put these bags in, and now there's machines that they've made that basically do the infusing and dwelling for you. And they're just, the tubing gets put in the machine, and it kind of circulates it into the patient's body, lets it dwell, drains it back out. Yes, there's complications with all of it, but it can work if it's done the right way. So what happens? This is basically peritoneal dialysis in a nutshell. Because it's hypertonic, dialysate causes all the electrolytes and all the waste products to be removed into that solution that's infusing, and then we drain it out of the patient, and then we do the next bag, and then we drain it out of the patient. So it's usually about 8 or 10 bags that this has to happen with. But imagine this is every single day. This is not 3 or 4 times a week, 3 times a week like chemo. It's every day the patient has to do this. So it's a lot to manage. So not everybody can manage this. So the hypertonic solution is instilled into the cavity to drain fluid and waste products. Treatment of choice for the older adult because they don't tolerate hemodialysis quite as well. Weigh the patient daily, that doesn't change. Sterile dressing changes around that catheter site itself. Surgical asepsis because we're worried about infection, and taking out what is important for this patient. Here's who it's recommended for. This is the same exact thing that it says in your book. People who don't tolerate anticoagulation. So you can't tolerate that heparin 3 times a week that we have to do with chemo. Somebody that has peripheral vascular disease. Why? Because that person has trouble with their vascular status already. We don't want to put a graft in and create that peripheral vascular disease to be worse. So that could be your diabetic patient that has poor circulation. That could be your person that's had peripheral vascular disease for 30 years. Putting a graft in might not be the best solution for them because we're going to make their circulation to their arm even worse. Patients who have chronic infections or unstable may not tolerate hemodialysis right then. It just depends on the patient. Again, not every patient fits into every single category. Somebody with chronic diseases that's going to have long-term dialysis might require peritoneal, and it might be a better solution for them. Again, depending on the patient and what's happening with them. Sometimes we use hemodialysis, sometimes peritoneal dialysis. What do you have to know about doing this? What could be your NCLEX question about peritoneal dialysis? You're going to warm it to room temperature. So when it comes to you, like from the pharmacy or whoever delivers it to you, wherever you might be working, it's usually going to be cold because it stays, the preservatives, it stays fresher longer if it's cold. So you're going to want it to be room temperature. You're not going to infuse into somebody's stomach cold solution. So that's the first thing. Make sure it's warm. You allow it to go in by gravity or using the machine that now the patient's insurance has covered because there's different machines out there now. Allow it to flow in. When you unclamp that clamp, it should flow in pretty quickly. Now, 5 to 10 minutes, and it's flowing right into the patient's stomach. What do you think could prevent it from flowing in? What if the patient's really obese? Maybe you might have to tell the patient, hey, lay on this side or that side to help it flow in a little bit better. If the tubing's kinked, could that prevent it from flowing into the patient's stomach and getting in there? So it's just stuff to think about, and this happens to you. You know, the tubing might be kinked. Maybe I forgot to unclamp the clamp on bag number 1, so it's not going to go anywhere if I don't undo the clamp. So you undo the clamp, have it flow into the patient, close the clamp. Otherwise, if the patient gets up, walks around, goes to the bathroom, some of it might shift back out. So what you want is you allow it to infuse, and you want it to sit in there. You want it to sit into the peritoneal cavity. Let it dwell. Maybe it has to dwell for 30 minutes. Sometimes the order might say dwell for 60 minutes. It's not usually any longer than that because the risk of infection would be there if I let it sit in there too long. So the dwell time would be listed by the order. Dwell time 30 minutes or dwell time 40 minutes or whatever it is. Now you're going to unclamp the clamp for 1 and put that bag, if you don't have a machine that's doing it, and it's just done by gravity, put the bag lower than the patient's stomach. What do you think is going to happen if I put the bag lower than the patient's stomach? It's going to, by gravity, drain back into the bag. Sometimes you might have to have the patient turn on their side or the other side. Turn toward the bag so that the fluid shifts from gravity and drains back into the bag. Allow it to drain. It might take 10 minutes or 20 minutes. What you want it to look like when it drains back out is clear straw color. Write that down. That's important. You want it to look like clear, like almost like I don't know, like hay, like a straw color, light tannish color. If it comes back out and it's cloudy, what do you think that might indicate? There might be an infection in the patient's stomach that we now can see has created a cloudiness in this drainage. That's a sign of peritonitis. What else could be a sign of peritonitis? Well, the patient all of a sudden starts developing abdominal pain. The patient starts running a temperature. The patient's white blood cell count goes up. We should be thinking, oh my, there's an infection happening in the peritoneal cavity. We better notify the doctor. And they'll probably stop peritoneal dialysis until we get the infection cleared up. So warm the solution. The dwell time will be listed for you. Let it drain. It should be clear, straw colored, very light, pale yellow maybe, but not cloudy and no signs of infection or pus or anything in it. And then monitor for infection. That's the biggest complication of peritoneal dialysis is an infection in the stomach, peritonitis. So the patient then would have pain. That catheter could potentially perforate the bowel. We would have abdominal pain, board-like abdomen. Remember, if they had that abdominal perforation. So again, these are just things that we have to think about might be our complication. Again, there's different types of peritoneal dialysis depending on what your insurance covers, what you're able to manage at home, how you're going to be doing this dialysis. There's certain machines that allow the patient to get up and walk around. After 4 more 6 hours of dwell time, you'll drain the solution, which now contains waste. So again, the cycle of this is going to be different than when we're just doing the bags by gravity. This one might be that through the machine, the amount of fluid that goes in dwells for 3 or 4 hours. It will all be ordered by the physician and set up through the machine. Again, this is a machine, continuous cycler assisted. This is a machine I've seen, and I saw a patient had this at Health South. It's an automatic machine that cycles the bags, and now they only need 3 to 5 exchanges, and they do it during the night while they sleep. And again, then you disconnect in the morning, and the patient's fine. They're not connected to it during the day. Usually, those patients get dialysis every single night, and they get hooked to the machine every night. So again, this is life-changing. The patients have to do this very frequently, and it'll all be determined by what the patient needs in order to keep their kidneys working. Look at this one, the one in the middle, the continuous ambulatory. They can walk around with it. It's a machine that does a lot of the work for the patient. And typically they need 3 or 4 exchanges during the day and 1 exchange at night. And again, a lot of patients like to do the exchanges at night because then they feel a little more independent and able to walk around during the day. So this would be something the physician and patient would decide upon and how this is going to work best for them. So again, here's us. If we're doing it by gravity, it might be 1 to 3 liters we're putting in the stomach. It's a big bag of fluid. It goes in, it sits in there for a dwell time, and then we drain it. And again, there's not one number that you need to recognize as always going to be the right number or right time. So don't memorize these numbers. Understand that every patient is going to be a little bit different. The dwell time will be ordered, and then if it's by gravity, remember one thing with gravity. If I know the bag contained 2 liters of fluid, that's like putting a whole soda bottle, and usually they do, usually 1 or 2 liters. If I put 2 liters in and I then drain it back out, how much do you think I should be getting back out? 2 liters. It makes sense that whatever I put into the patient, I want to see that come back out when it drains back out. It should be clear and straw colored, but whatever I put in should come back out pretty close to it. What's going to happen if I put in 2 liters and all I drained back out was 1 liter? What's happened? I now left an extra liter inside of the stomach into the peritoneal cavity, and now I hook the next bag. And then suppose bag number 2, I don't get 2 liters back out. You got the picture of what's happening. I'm leaving too much in the patient's abdomen. So remember, whatever you're putting in should be pretty darn close to what you're getting back out. Within, 10, 20 mLs, you should recognize I put 2 liters in. When I drain it, I should get 2 liters back out. So every patient's dialysis order for peritoneal will be a little bit different, depending on the type of machine. As medicine evolves, the machines are getting more and more sophisticated, and maybe the patient only needs 3 exchanges at nighttime instead of 8. Again, patient-specific. Insurance dictates what they can do. The patient's cognitive status dictates what they can do. The patient having somebody at home that can help them do this. Certain machines that patient has to do every day. Again, if they can do 10 or 14 exchanges through a really high-tech machine or more recent machine, maybe they only have to do it 3 times a week. So again, these seems like pretty good odds to do this at home, but it doesn't go without complications either. So just remember, it doesn't always work for every patient. This is just a picture that I was showing you. What's the advantage? More independence. They can eat a little bit better. Maybe their kidneys aren't quite as bad as the hemodialysis patient. Typically, their labs get a little bit better. Obviously, when they're doing peritoneal dialysis, that's the point of it. It's the least expensive, decreased likelihood of future transplant rejection. So again, maybe we can catch the patient in an earlier stage of kidney disease, and this works for a while. Sometimes it doesn't work for patients, and the doctor says, hey, you need hemodialysis. This is not working for you. Okay, so any questions about peritoneal dialysis?
So if it's out of that window, I can't be able to get an appointment. They charge